It is my pleasure to host today in this Ask the Session author, Professor Cyrielle Caussy, who recently co-authored a publication in Diabetes Care entitled Screening for Metabolic Dysfunction Associated Steatotic Liver Disease Related Advanced Fibrosis in Diabetology, a prospective multicenter study. So one challenge in the field currently is to identify patients who may need to be treated or at least managed for this disease, as we discussed recently with Professor Castera. And in this publication, the highlight is how to put in place a clinical pathway. So we are very lucky to have with us Professor Caussy, who is an expert in diabetology and especially in fatty liver disease. So Cyrielle, thank you first for taking the time, and congratulations to you and your co-author for this publication. Can you describe to us what is the design of the study?
So the design of the study was very simple. At the time we designed it, there were no data of a screening strategy performed in diabetology. All the data and also the diagnostic accuracy of the NITs tests that are recommended come from patients with biopsy-proven MASLD that are usually recruited in hepatology. So we really wanted to see what would be the distribution of NIT and diagnostic accuracy when they are performed in the actual clinical setting in diabetology and nutrition clinic. We enroll patients with type 2 diabetes and obesity, which are known to be at risk of advanced fibrosis. And we perform at the same day all the available non-invasive tests, blood-based biomarkers such as the FIB-4 that we all know, but also NAFLD fibrosis score, patented score like fibrometer, fibro test, and the ELF test. And we also perform liver elastography using different devices, the FibroScan for liver stiffness measurement, but also shear wave elastography using an Explorer. And some of the patients have also magnetic resonance elastography. Of course, we excluded patients with other causes of liver disease. Every patient had MASLD because they have hepatic steatosis on ultrasound. And we excluded patients with a high BMI greater than 40 kilogram per meter square because the liver stiffness measurement in this population may not be very accurate and may be false positive.
And with this strong methodology, what did you find?
Well, what we wanted to do is also risk classify as accurately as possible our patients. So what we use is a hierarchical composite criteria to define the presence of advanced fibrosis. Because all of our patients could not have a liver biopsy, many of them were at low risk and it would have been unethical to perform a liver biopsy. So what we did is first use the liver biopsy if it was performed in this population to classify the presence of advanced fibrosis. If not, we look if the patient have a magnetic resonance elastography, which is the second most accurate non-invasive test, and we classify it based on that. And if not, we classify based on liver stiffness with low risk defined below 8 kilopascal, which is not a recommendation. Between 8 and 12, it was patient with intermediate risk, and above 12 kilopascal, the patient with high risk of advanced fibrosis. And with that, we were able to define that there were 18% of our population that were high or intermediate risk for advanced fibrosis and actually need to be referred to hepatology. And when we applied the two-step strategy using first the FIB-4 and then liver stiffness assessment, we demonstrated that he has a very good diagnostic accuracy. He was able to classify the patient at low risk with a high negative predictive value, but we were also able to identify the majority of the patients that needed to be referred to the hepatologist. So it's not the perfect, it's not 100% of them, but it works pretty well, and it's really the first study that demonstrates that we can use this two-step strategy. We also demonstrate that you can use potential alternative second-line tests, such as the ELF test, which is the most accurate second-line strategy, using an adaptive threshold with a low threshold of 9.8 to risk stratify the patient. And we can also use, if we don't have access to any of these tests, shear wave elastography using an ultrasound using the same threshold of the FibroScan, 8 kilopascal. It performed a little bit less well, but still it's a reasonable alternative. So we are really showing that these two-step strategy are actually applicable and will be efficient in our population.
So now what would be the advice that you can give to others who would try to put in place such a clinical pathway?
So my advice is just do it. There's a lot of people that are not sure whether it's going to be a tsunami, a lot of patients to refer, or what to do with the screening strategy. We actually shows that with very simple tool, starting with a FIB4 in diabetology, it works quite well. The majority of the patient will be classified at low risk, and you will have nothing to do more than just reassure your patient. But for those you identify with an elevated FIB4, go for a second line test, the one that you have available in your setting. And this will also help to identify really the one that needs to be referred. I just want to highlight that in this screening strategy, we did find patients with compensated cirrhosis that had no idea that they had cirrhosis. And this is really something that needs to be found and identified. So just my advice is use the tools that are recommended. It is working, and please go for it.
Fantastic. We should go for it. Thank you very much, Professor Caussy, for your time. Thank you.
Thank you, Jean-François.